Giovanni Tebala. I'm a surgeon. I work in the UK. I've been working here for several years. My main field of interest is bowel surgery. Every aspect of bowel disease, from cancer to diverticular disease. Diverticular are small pockets in the wall of the bowel. You must just imagine this big tube, which is the bowel, with some bumps laterally. Normally, they form due to an increased intra-intestinal pressure. So these pockets, normally they are totally asymptomatic. They are there, no one knows they're there. They don't normally cause any symptom. Sometimes they can get stuck with feces or inflamed and can give symptoms. This is what we call diverticular disease. The presence of diverticula alone with no symptoms is called diverticulosis. The presence of symptoms is called diverticular disease. Now, these symptoms can be acute, meaning that they can present quickly, suddenly, with a stabbing pain, general feeling unwell, sometimes with bleeding, sometimes with obstruction. This is due to an inflammation of the diverticula. The inflammation of the diverticula can be acute, as described, or can be subacute or chronic inflammation. An acute inflammation of the diverticula is called diverticulitis. Diverticulitis happens normally when one or more of the diverticula are infected or inflamed. We don't really know why this happens. There are several different theories of the reason why at some point in some person diverticula tend to get inflamed. Someone says is a primary inflammation of the bowel and then transmits to the diverticula, which may be true in some cases. Someone else says, no, it's a problem of the diverticula. They get inflamed because they get stuck with feces. The bowel doesn't work properly. So feces remain into the bowel for a long time and create inflammation. Both of them can be acceptable, but no one really knows the definitive answer to this question. In the so-called diverticular disease, which is, as I said, the presence of diverticula with non-inflammatory symptoms, so mild symptoms, the symptoms of diverticula can be similar to irritable bowel syndrome, which means pain in the left lower abdomen, sometimes on the right as well, bowel quite irregular, feeling bloated. These are the general initial non-specific symptoms of diverticular disease. When the diverticula become inflamed, the most evident symptoms is normally pain. Pain can be stabbing as a knife in the abdomen, normally in the lower abdomen, sometimes on the left, rarely on the right side. Pain can be associated with a fever, with a feeling really, really bad. Other symptoms may be, as I mentioned, bleeding. Bleeding is one of the symptoms where that can be associated with inflammation of the diverticula. Sometimes difficulty in opening the bowel, but the most frequent symptom of the diverticulitis is pain, fever, and feeling unwell. No one knows why the normal, innocent diverticula at some point become complicated and become infected. Sometimes these may be related to the diet, sometimes may be related to other medication the patient is taking, but no one really knows the answer of why the diverticula tend to get inflamed and why in some patients there may be several episodes of diverticulitis during their life, and some other patients with diverticular don't have any problem for the whole life with diverticular. They know possibly that they have diverticular in their large bowel, but without any symptom. It is not clear why this happens in some patients and doesn't happen in some other patient. Once we have the symptoms of diverticulitis, diverticulosis, diverticulitis, the first step is trying and understand what is the real situation. Because an inflammation of the diverticulitis can be more or less complicated. A non-complicated inflammation of the diverticula, non-complicated diverticulitis, usually presents with pain and a bit of fever and feeling unwell, no more than this. And it's just an inflammation of that segment of bowel where the diverticula are, but no more than this. Sometimes the diverticulitis is complicated when there is something else other than the inflammation of the diverticula, such as a perforation of the bowel, such as an abscess. In these cases, perforation or abscess of the bowel, abscess is a cavity full of pus. Of course, they cause much more severe symptoms. An abscess may cause sepsis, perforation causes a peritonitis. So if a patient has a sudden peritonitis, which means diffuse pain in the abdomen with feeling extremely unwell, fever, low blood pressure, of course, this is a sign of a severe inflammation with possibly a perforation of the diverticula. A perforation of one or more diverticula causes an inflammation of the whole abdomen and spread of feces, pus, whatever is in the bowel, in the whole abdomen. You can understand this is an extremely emergent situation that needs to be treated as an emergency as soon as possible. A patient who has these symptoms, of course, needs to be seen by a doctor, which may be in the A&E in the hospital or by a consultant surgeon. Anyway, someone who has experience in the treatment of bowel conditions. Before establishing which kind of treatment is the most indicated in that particular case, it is mandatory to do some investigations to understand exactly what I told before. Is it a simple diverticulitis? Is it a complicated diverticulitis? Is there anything more than diverticular? So a diagnostic phase is extremely important before we can establish the correct treatment for diverticulitis. Simple symptoms of diverticulosis or diverticular disease usually can be treated with medication, diet, and an healthy lifestyle. But the acute presentation of diverticulitis needs urgent medical attention. The first step of treatment is usually painkillers and antibiotics. Few years ago, diet was much more important. And now we know that other than an healthy diet, there's nothing really to be completely avoided, even in case of diverticulitis, if we're talking about a simple, non-complicated diverticulitis, but mostly trying to keep the bowel flushed and working regularly with laxative. So antibiotics, laxative, plenty of hydration, painkillers for the simple acute diverticulitis. Even antibiotics, we're not completely sure if antibiotics are really indicated in acute uncomplicated diverticulitis. Some recent evidence suggests they may not be useful. And the recent guidelines suggest not to use antibiotics, even if we are in the presence of an acute diverticulitis, unless there is a clear indication, such as the risk of progression to something a bit more severe, or not responding to the initial conservative treatment without antibiotics. But there is no need to start immediately with antibiotics. Painkillers, diet, hydration should be more than enough. In the case of complicated diverticulitis, such as with an abscess or with a perforation, of course, the treatment is a bit more complex. A small abscess can still be treated with antibiotics. A large abscess must be drained. This drainage can happen through a small incision of the abdomen, a small puncture of the abdomen, through a ultrasound guided or CT guided procedure, or with the surgery, with keyhole surgery and laparoscopic lavage. Lavage or washout is a procedure when we go into the abdomen and clean and drain the pus and the inflammation just by washing and sucking without touching the bowel. If there is a perforation with a widespread contamination of the abdomen, a proper surgical operation with resection of the diseased bowel is mandatory. So in case of perforation with diffuse peritonitis, I'm afraid that the only possibility is a surgical operation that may still be feasible with keyhole surgery, provided that there is adequate knowledge and skill set to do that, but can be done with a keyhole surgery usually, and normally entails the excision of a segment of bowel, and then the decision of what to do next. Traditionally, in this kind of patients, after the excision of a segment of bowel, the operation was to create a stoma. So to fashion a stoma bag where the feces go outside the abdomen for a period. This was because it was considered unsafe to rejoin the bowel immediately, in particular in the presence of contamination in feces. Fortunately, things are changing in the last period, because this 1 century-old operation of colostomy is slowly being abandoned. And now all the evidence suggests that in most cases it is feasible to remove the bowel, remove that part of the bowel, and then rejoin immediately, with a huge advantage for the patient, who doesn't need to wear a stoma bag, doesn't need to have a second operation for reversal. Also considering that reversing a colostomy bag is something that can happen in about half of the population. More than 50% of patients after colostomy are never reversed. And this, of course, is a huge discomfort for the patient, for the whole society. About the treatment, there's something else that we need to add, and is what to do with the patient that coming with an acute diverticulitis are treated with antibiotics. The situation just resolved by itself with antibiotics, with the treatment. Do they need to have a surgical operation afterwards? There's a big discussion. Some of those patients may still need an operation, which can be done as an elective case, not in emergency, to remove that part of the bowel, in particular if there are ongoing symptoms, even when the acute phase is gone. In those patients who continue to have symptoms of pain, irregular bowel, discomfort, in particular in the lower abdomen, surgical operation should be considered. Operation is pretty much the same: keyhole surgery, excision of part of the bowel, and immediate anastomosis, which means immediate rejoining the bowel. Of course, if we can do this operation as an elective procedure when the inflammation has gone, procedure is much easier, quicker, recovery is smoother, and there is no risk, or at least a low risk, of having a stoma, which is something that, if it can be avoided, it would be much better. As regards surgery, there are not many alternatives. Surgery is surgery. Depending on the situation, surgery can be conservative, as I mentioned before, with a laparoscopic washout, which means keyhole, washing the inflammation out, removing the pus, leaving a big tube inside to drain the pus out for a few days. And this is very effective in selected patients. In patients who have perforation, peritonitis, or even a chronic inflammation causing a progressive stricture of the bowel, causing progressive constipation, the only option is an excision of the bowel, a resection of the bowel, and possibly immediate anastomosis. Some surgeon, I can understand, some surgeons may be a bit risk averse. They don't want to risk anything because in this kind of surgery, the risk of anastomotic breakdown, which means leak from the suture, is possible. The risk is less than 10% anyway in good hands. Some surgeons don't want to even risk that 10% of risk of leakage, so they prefer to create a colostomy bag. I think they forget that while they create a colostomy, they create a new disease, because a colostomy itself is a new disease, because it's associated with other complications, quality of life impairment, a second operation with a second risk with general anesthetic, a much more complex second operation. So yeah, I understand being risk averse, but in this case, we need to be able to take our courage and say, okay, if the conditions are correct, try and rejoin immediately as much as possible.